Hello, my name is Rhiannon Harms, and I'm on the analytics team at Unity Point Health, a large nonprofit health system based in the Midwest with more than 20 hospitals, 400 clinics, and 33,000 team members. I'm joined today by Dr. Marcel DeVetten, who leads our clinical leadership group. We're excited to have a little of your time today to talk about a multi-year journey around blood management here at Unity Point Health. That efforts included the development of a blood management program and the development of an analytics platform that allows us to monitor utilization of blood products. Additionally, it includes some advanced modeling that allows our providers to understand what their peers across Unity Point Health would have done in terms of transfusion decisions if providers would have seen patients with a similar acuity and care setting. So we're now in the 7th year of our year-over-year improvement, which means we've had more than 20,000 patients who weren't exposed to a transfusion. We've saved more than 78,000 transfusions and resultingly have had $24 million in savings as well. So really exciting to see the savings year over year, but most importantly, that our patients are staying well and safer. So with that background, let's get into the good stuff. Dr. DeVetten, a few questions for you. Tell us about the clinical leadership group structure at Unity Point Health.
Sure, thank you, Rhiannon. And obviously, as a hematologist, the example that you just gave about reducing variation work really appeals to me. So the clinical leadership group structure within Unity Point Health is a group that is composed of clinicians, individuals with an operational background, and a few individuals who bring backgrounds around areas such as finance, IT, and analytics to the table. We meet on a regular basis and we continue to ask ourselves the question, what is the strategic vision of the organization? And what type of clinical initiatives are most likely to get us closer to accomplishing that strategic vision? And in many cases, that comes down to defining a question more clearly that then allows us to partner with our analytic friends. What I mean by that is by essentially, such as in the case of the example that Rhiannon mentioned, ask the question, when the literature shows that reducing the amount of blood transfusions for many conditions in which it was previously felt to be appropriate is probably the right thing to do, where are we as an organization? Where do we stand? How are we doing? That's a question that can be answered based upon information that we have available. Not surprisingly, when you answer that question, you often discover variation. That variation then drives the next question, which is how can we develop a system that allows us to reduce that variation, and how do we do it in such a way that the system is actually appealing to physicians and clinicians, that the system makes it easy for them to do the right thing, that the system allows them to opt out and do something different than what is suggested when they feel that there is clinical justification to do so. And then it becomes a matter of continuously monitoring, sharing those results back, and developing some momentum and enthusiasm around the individuals who now see that their actions result in better outcomes for patients and, not unimportantly, savings for the organization.
Great, thanks. That's really important. So you mentioned the analytics team and the partnership there. Maybe talk a little bit about how the analysts support the medical directors and any maybe secrets you have on good partnerships.
Absolutely. I hope there's really no secret here. To me, the secret is in the word partnership. So under our clinical leadership group, we have developed several service lines, mostly focused on specialties that operate across all of the regions, hospitals, and care settings where we operate. So we have service lines in cardiovascular medicine and inpatient medicine and emergency medicine, etc. Every service line is led by the dyad of a medical director. usually a physician within the specialty of the service line, as well as an operational leader, in general, one of the CEOs of one of our hospitals. And every service line partners closely with an analytics resource, and they continuously ask the question if there are standards within our particular practice that we expect to result in better outcomes, such as every patient with condition A should be treated with intervention B, or intervention A has shown to be superior to intervention B for patients with a particular situation. You know, can we measure how we're doing? Can we describe the variation that we're seeing? Can we understand what's driving that variation? Can we come up with ways to reduce that variation? And again, can we do it in such a way that we make it easy and appealing for clinicians to participate in this reduction of variation work? Our analytics partners are essential in that space because they are the ones who in essence translate our questions into a query of various databases, come back with initial answers that in many cases need to be fine-tuned based upon sub-questions or refined questions until we feel that we get to a space where we have an initial answer that is at a point where we can test the hypothesis. And then the hypothesis becomes, if we make a change, does it actually reduce our variation? Does it drive better improvement? We try to implement the change. And of course, the analytic platform is where we continue to look to see if the change has the effect that we hope it will have on patient outcomes.
Great. So a lot of continuous learning informed by evidence and data. So maybe before we sign off, curious on any last thoughts you have for the audience today, and maybe any lessons learned from this multi-year journey that you'll make sure to apply forward to other clinical improvement efforts.
Yeah, I think if there is one thing we have learned, Rhiannon, and you will likely agree with that, is that the medical model, unfortunately, is one where we tend to jump to conclusions. We see a problem, and without even studying the problem, we have the solution right there. And if everybody were just to do A or B or C, then for sure we will fix the problem. And in many cases, we try very hard, and in most cases, we are unsuccessful. I think the one thing that we have learned is to take a step back, really study the data, let the data drive the discovery process, and then let the discovery process drive any hypothesis, and remain open-minded about those hypotheses. You know, implement something, see how it works, be open to the possibility that your hypothesis is wrong and that you might have to change again. So from my perspective, the big learning about this is to become data-driven as an organization, much more so than intuitive-driven.
Great. Well, thanks so much, Dr. de Wetten. I think on behalf of both of us, we want to thank you all for joining us, and we look forward to meeting you all virtually at HAS this year. Thank you.
Thank you.